This is Chapter 18, Cardiovascular Emergencies. Your standard competencies. The pathophysiology, it applies to comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. In medicine, it applies to the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient. For cardiovascular, we're going to be talking about anatomy, signs, symptoms, and management of chest pain, cardiac arrest. Acute coronary syndromes, which is angina pectoris and myocardial infarctions. What's that a fancy word for? Heart attack. Aortic aneurysm and dissections, thromboembolism, heart failure, and hypertensive emergencies. All the fun stuff. All right, the AHA, or the American Heart Association, estimates that one person has an acute myocardial infarction, also called an AMI, in the United States approximately every 40 seconds. Heart disease has been the leading cause of death in Americans since 1900. We need better public awareness, early access to EMS, increased numbers of lay people trained in and willing to do CPR, public access to defibrillation devices, recognition of need for advanced life support services, and transportation to hospitals that can provide coronary catheterization and post-arrest care. Someone's trying to come into class. It is Brandy Dawn. Okay.
Hey,
Hey.
hey,
Hey.
okay, I'm sorry to interrupt your class for this,
You're fine.
but it's the easiest way for me to get everybody, I don't even know who y'all's on here, but it's the easiest way for me to ask the question without having to sit here and text everybody because I just texted Madison and interrupted her. So this is the easiest way. We have a trip going to Mississippi.
All right. Anatomy and physiology review. This is the anatomy review. Cardiovascular system consists of the heart, blood vessels, and blood. The structures of the heart. The heart is the muscular, cone-shaped organ whose function is to pump blood throughout the body. The heart muscle is referred to as the myocardium. The pericardial sac is a thick, fibrous membrane that surrounds the heart. The visceral layer of the pericardium lies against the heart, the epicardium, and the pericardial fluid reduces friction within the pericardial sac. The endocardium is the smooth inner lining of the chambers of the heart and the surface of the valves. Each atrium receives blood that is returned to the heart from other parts of the body. Each ventricle pumps blood out of the heart. The valves of the heart, these include the atrioventricular valves and semilunar valves, tricuspid valve and the mitral valve, the aortic valve, and the pulmonic valve. The papillary muscles in the ventricles contract to tighten the chordae tendineae. And there is your nice figure to refresh your memory on where each part is in the heart. The coronary circulation. Coronary arteries supply oxygen to the heart. Coronary circulation emanates from left to right coronary arteries. The left main coronary artery divides into the left anterior descending, or the LAD artery, and the circumflex coronary artery. The supply of blood to most of the left ventricle, the intraventricular septum, and at times the atrioventricular or the AV node. Coronary arteries supply oxygen and nutrients to the heart. The first picture there, picture A, is the anterior view, and picture B is the posterior view. Blood vessels. Blood is transported through the body via arteries. The aorta is the body's largest artery. Arteries branch into arterioles, then capillaries, which eventually enlarge to form venules. Two large veins, the superior vena cava and the inferior vena cava, return deoxygenated blood from the body to the right atrium. Blood from 4 pulmonary veins enters into the left atrium. Blood flow through the heart is shown here. Figure A is the flow of oxygen-poor blood from the venous circulation, and B is the flow of oxygen-rich blood from the pulmonary veins through the left side of the heart into the aorta. The blood and its components. Blood consists of plasma, red blood cells, RBCs, and white blood cells, WBCs, and platelets. Red blood cells contain hemoglobin, which binds to oxygen and carries it to the tissues. White blood cells are leukocytes. They fight infection. Platelets play an important role in the blood clotting process. The electrical conduction system. The pumping of the heart occurs in response to an electrical stimulus initiated by a conduction system. The sinoatrial or SA node is the normal site of origin of the electrical impulse. It has an intrinsic rate of 60 to 100 beats per minute. The impulse spreads out through the rest of the conduction system, resulting in ventricular contraction or systole. The electrical conduction system of the heart initiates an electrical impulse throughout the heart. The impulse travels through the 6 parts of the cardiac conduction system shown here in this figure. The electrical properties of cardiac cells. You have excitability. This is the ability of cells to respond to electrical impulses. Conductivity is the ability of the cells to conduct electrical impulses, and the automaticity, and that's the ability to contract without a stimulus from a nerve source. Your physiology review. Regulation of heart function. The heart's chronotropic state, dromotropic state, and inotropic state are controlled by the autonomic nervous system. Receptors in the blood vessels, kidneys, brain, and heart constantly monitor body functions to maintain homeostasis. What's homeostasis again?
The natural balance.
Natural balance. Baroreceptors respond to changes in pressure, usually within the heart or the main arteries, and chemoreceptors sense changes in the chemical composition of the blood. Your cardiac cycle is the process that creates the pumping of the heart. The cycle begins with myocardial contraction and concludes at the beginning of the next contraction. Systole is contraction of the ventricles and the pumping of the blood into the systemic circulation, and diastole is the relaxation of the heart. Your preload is the amount of blood returned to the heart to be pumped out and directly affects afterload. Afterload is the pressure in the aorta or peripheral vascular resistance against which the left ventricle must pump the blood. Cardiac output equals the stroke volume times the heart rate. Factors that influence the heart rate, stroke volume, or both will affect cardiac output and perfusion. The Starling law of the heart is increased venous return to the heart stretches the ventricles to some extent, resulting in increased cardiac contractility. The ejection fraction is the amount of blood returning to the right atrium. It may vary from minute to minute, but the normal heart continues to pump out the same percentage of blood. Blood flow within the heart. Blood from the upper part of the body returns to the heart through the superior vena cava. Blood flow from the lower part of the body returns through the inferior vena cava. In the lungs, blood is oxygenated and carbon dioxide and other waste products are removed. Freshly oxygenated blood is returned to the left atrium through the pulmonary veins. After oxygenated blood has been delivered by the capillaries, deoxygenated blood is returned to the heart. Pulmonary circulation carries the blood from the right side of the heart to the lungs and back to the left side of the heart. Systemic circulation is responsible for blood flow to the rest of the body. Systemic arterial circulation. Oxygenated blood leaves the heart through the aortic valve and passes into the aorta. From the aorta, blood is distributed to all parts of the body. The pathophysiology. Chest pain or discomfort that is related to the heart usually stems from cardiac cell ischemia. Decreased blood flow to the heart muscle. Heart tissue fails to get enough oxygen and nutrients. Tissue soon begins to starve and eventually dies if blood flow is not restored. So the word ischemia is simply telling you that there's parts of the tissue that are not being oxygenated. Atherosclerosis. Most often, diminished blood flow to the myocardium is caused by coronary artery atherosclerosis. Cholesterol and other fatty substances build up and form a plaque inside the walls of blood vessels. Atherosclerosis can cause complete occlusion. Damage to the coronary arteries may become so extensive that they cannot accommodate increased blood flow at times of increased need. This can cause a reduction in blood flow. And that picture there shows you how the plaque builds up and forms the occlusion. Thromboembolism is a blood clot that gets stuck at a narrow area and blocks the blood flow at that point. Acute myocardial infarction, or an AMI, is a blockage that occurs in a coronary artery. Major controllable factors are cigarette smoking, high blood pressure, elevated cholesterol levels, elevated blood glucose level, or diabetes, lack of exercise, and stress. Acute coronary syndrome. This term is used to describe any group of symptoms consistent with acute myocardial ischemia. Myocardial ischemia is decrease in blood flow to the heart. The signs and symptoms of these two conditions are very similar, and they are treated similarly under the designation of ACS, which stands for acute coronary syndromes. Angina pectoris is a brief period when heart tissues are not getting enough oxygen. It is also called simply angina. It's defined as a brief discomfort that has predictable characteristics and is relieved promptly. Angina pain is typically described as crushing, squeezing, or like somebody is standing on my chest. It's usually felt in the mid-chest under the sternum but can radiate to the jaw, arms, mid-back, or epigastrium. Where's the epigastrium?
It's in the middle of your tummy, ain't it?
It's right at the well, where your diaphragm is, right where your stomach meets your chest. That little point right there in the middle. Like if you ask a patient, or if you see your partner ask a patient to point to where they're hurting, and they point right there, and you're like, okay, well that's right at the bottom of the chest and right at the top of the stomach, where the two meet. That's your epigastric area. A single episode may be a precursor to a myocardial infarction. Stable angina occurs at a relatively fixed frequency and is usually relieved by rest and/or medication. Unstable angina occurs without a fixed frequency and may or may not be relieved by rest and/or medication. Progressive angina is stable or unstable angina that is accelerating in frequency and duration. Acute myocardial infarction. Most deaths from AMIs are caused by dysrhythmias. Dysrhythmias can often be prevented or treated. Pain of AMIs signal the actual death of cells in the area of the heart where blood flow is obstructed. Angioplasty or percutaneous coronary intervention, also called PCI, has shown to be the most effective treatment. Signs and symptoms are sudden onset of weakness, nausea, and sweating without an obvious cause, chest pain, discomfort, or pressure, pain, discomfort, or pressure in the lower jaw, arms, back, abdomen, or neck, irregular heartbeat, and syncope, shortness of breath or dyspnea, pink frothy sputum, or sudden death. Physical findings of AMI. General appearance, patient often appears frightened. The pulse increases as a normal response to pain, stress, fear, or injury to the myocardium. Blood pressure may fall as a result of diminished cardiac output. Complaint of difficulty breathing is common, and patients sometimes experience an almost overwhelming feeling of impending doom. What does that mean? What does it mean to feel impending doom?
They feel like they're going to die.
Yes.
It's when your patient looks like they says, I'm going to die. I'm going to die.
Yeah. They may not know exactly what's going on. Some patients that are having heart attacks don't present, and like the most common symptom is chest pain. However, you have different factors. African Americans, women, diabetic patients, they may not have chest pain at all. They may have a pain in their abdomen. And you can have any of these pains, the pain in the jaw, neck, back, arm. You may have that pain without a chest pain. Um, if a patient ever tells you, I feel like I'm going to die, or I feel like something is very bad wrong, or I feel like something's going to happen and I just don't know what, those are feelings of impending doom. Pay attention to those. When your patient says that, if they exhibit a feeling of impending doom, you need to pay attention to that.
Why do they feel that way? Like, is there a scientific cause for that? How they just know?
I don't think that there's anything scientific like that just pinpoints, okay, this is what causes this. I think it's not necessarily scientific, maybe a more spiritual level. Your body is in this constant, that's why it keeps throwing homeostasis at you. Your body is in a constant balance, battle for balance within itself. Your body knows when something's wrong or when something is going to be wrong before you do. And your whole body works together as a system. So you have got your cardiac and your, GI and your neuro all working together simultaneously. So this is occurring within an instant. That your heart may sense that something's not right. Your enzymes may be off balance. There may be a blockage there. It's trying to balance that out. So, in the sense of while it's trying to restore the heart, it's going to pull things away from, let's say, your GI and your urinary tracts so that it can focus on saving the heart. So, that part of the body starts to slow down to send all of its resources to the cardiac. You with me so far? Your brain interprets that these changes are happening in the body. So my theory, subconsciously, your brain knows that something's going on in the body. And so then you start getting those thought processes, those hormone changes, those emotional reactions that your brain hasn't processed yet because it doesn't know exactly what's going on yet. Does that make sense?
It does.
That's my theory on it.
Because me and Robert, we ran a patient, and before we could even get them in the truck, they were like, I'm going to die. I'm going to die. And Robert was like, no, you're not. You're not going to die. And then before we could even get him in the truck, we had to start compression.
Yeah.
That was the craziest thing I've ever seen in my life.
Those things happen. I've had a couple of patients that have either said that in front of me and then they died when they were seemingly nothing was wrong. And like when you're assessing this patient, you think, okay, this is anxiety, this, just stay calm, good deep breaths. You're trying to calm them, and then they actually do code. I've run a code at a doctor's office where the last thing the patient said was they sat up and said, I'm going to die. And then they literally fell over dead. Um, the whole, you can die from a broken heart thing. I've been on scene coding a patient and they called death in the field on the patient, and I walked in the next room to tell the patient's sister that, hey, I'm sorry. We did everything we could, but he's passed away. And she coded as soon as I told her. Your body does things that we can't always explain. And the feeling of impending doom, that's one of those. Like sometimes your body just knows.
Okay.
It's very interesting. It really is. But I promise you, if they tell you that, and they're not going to say, "Oh, I have a do what."
Like it's so crazy that like the body can do that.
It is. It really is.
Like it's crazy on half the stuff the body can do, but like especially just feeling a certain way, like they just know, like that's insane to me.
It really is. And like people, you don't think about it until you just really sit down and it's pointed out and you think about it. But like the body and how it works together and the mind and how it functions is a really amazing process. And your patient's not going to say, I have a feeling of impending doom. They're not going to use those words, but they're going to use words that indicate that that's what we call it. They say, I just feel like something horrible is going to happen, or I feel like I'm fixing to die. And you can say, well, why do you feel that way? And they say, I don't know, I just do. So pay attention to any words like that. Um, that fall into that impending doom category, because I'm telling you, they know.
Madison, I'm telling you right now, the first time you see it, it's going to blow your mind because I looked at that patient and said, boss, he's not breathing. We got to start doing compressions. They checked his pulse and he was like, crap. That's how quick it happened. He said, I'm going to die. And then I looked at him and said, why do you feel that way? And he said, I don't know. And then we started compressions.
Yeah.
That is like, God, like, that is insane. Like, that's like mind blowing to me.
It is. And you may have patients that make a final statement, or, hey, tell my kids I said this, or they might glance off into the distance and be like, wow, that looks beautiful, or they may say something about seeing an angel, or they may be speaking to their deceased loved ones. You better be ready to.
What is it again? Like when older people like don't. What is it when they like start reaching?
Yeah, I know my screen just went black. They'll start reaching out, because a lot of people who are in those stages of passing, they will see loved ones that have crossed over, and they reach out for them when they see them. I mean, if you imagine, I mean, one of my favorite dogs that I had for 17 years. If I'm in the process of dying and I have this vision and I see my dog, I'm gonna reach for him. You see a you see a grandparent, you see any loved one that's no longer here, and you have this vision of them and you can see them clearly. You're gonna reach for them. Those are.
I took somebody to Riverview, and as soon as we like walked into Riverview, he started like reaching up, and the only thing I could think of was, "Oh my God, can we please get him off my car?"
Yeah, those are gestures of impending doom. Absolutely. And pay attention to those, because I assure you, when they do that, when they get that stare, when they start speaking to people that have passed on, when they start reaching for people, when they have, I feel like I'm going to die, believe them.
They will try.
It is. It's crazy and it's amazing. It really is.
I had a 19-year-old in a really bad wreck. He had a head injury, and we were talking to him, and all of a sudden he just started saying, "Oh my God, that is so beautiful.
Yep.
Oh, that's so beautiful." And we put him in the ambulance, and he coded.
Yep. Absolutely. Me and Tiffany had a patient that we picked up, and she'd been talking to family members like they were sending her out for altered mental status. Vitals were good. She really didn't have anything wrong, but she was talking to people that weren't there. We get her in the back of the truck, and I looked in her eyes, and I could see that glance. She was talking to her mama. And so I stood up because I saw it coming. I stood up and went to the airway cabinet to get my intubation roll, and I didn't even have it in my hands yet. I'm sorry, it wasn't Tiffany, it was Karen. Um, I didn't even have it in my hands yet. And Karen said, "Hun," I said, "I know, start compressions." We did 2 minutes of CPR and got her back. It was crazy. But yeah, she was talking to family that wasn't there, and I could just see that glare in her eyes. She was not here mentally. She was not here. And whatever she was looking at and seeing wasn't anything physical that we could see. So I knew then to get my stuff ready because she was fixing to go with whoever she was talking to.
I literally just got chills.
Yeah.
That look is such a, like, you know it when you see it, and there's no way that I can describe it. You just know it.
I call it the death stare. She's got the
Like
death stare.
the first time you see it, you know what it is, and you're like, oh crap.
Yeah. Yeah. It's crazy. Oh, I'm touching buttons. Okay. So that yeah, that's one of my favorite things is the impending doom stuff because it just amazes me. It really does. Consequences of an acute myocardial infarction is sudden death. This usually results of cardiac arrest. The heart fails to generate effective blood flow, cardiogenic shock, and heart failure. There's a variety of other lethal and non-lethal dysrhythmias that may follow an AMI. Tachycardia, that's a heart rate greater than 100. Bradycardia is a heart rate less than 60. Ventricular tachycardia, that is when the heart rate is being generated from the ventricles. We talked about before where the SA node, the node at the top of the heart, the sinoatrial, that's the heart's natural pacemaker. So as the heart begins to fail, when that pacemaker doesn't work the way it should, it goes to the next node. And when that one fails, it goes to the next node. That's why a lot of times you'll see this, it'll be progressive. They may start out with a normal rate and then it'll gradually fall and you'll see rhythm changes. It'll change and it'll stay steady for a little bit, then it'll change again. That's those pacemakers, those nodes as they quit working. And you have to remember, like, your heart is a muscle. Muscles become tired. So as the heart is working over to try to compensate and to try to survive, parts of this muscle become fatigued. So it goes to the next node and it goes to the next node. That's why the last rhythms you typically see, unless this is a sudden, massive heart attack, if this is just kind of like a natural or slow progression, the last rhythms you're going to see are the ventricular rhythms, the VTAC and the VFib, because that's where the last pacemakers are in the heart. So when you get to ventricular tachycardia, this is the fun stuff because we're teaching you that tachycardia is a rate greater than 100 beats. That's true. However, that is a normal rate. We're talking about your heart's functioning properly. This is a normal sinus rhythm, okay? As you go further in your EMS career, if you go on to medic and you get deeper into cardio, you're going to learn that each portion of the heart, each node has certain rules, and one of the rules is the rate. So the ventricular rate, your ventricles will beat naturally between 20 to 40 beats per minute. That's their baseline rule. So when we talk about ventricular tachycardia, that doesn't mean that this rate's over 100. That means that this is a tachycardic rate for that node. So if that node generally beats 20 to 40 beats per minute, anything over 40 is going to be tachycardic. Does that make sense?
Yes.
Okay. So when we say, let me scroll back down my notes here. So when we start saying ventricular tachycardia, we mean that the ventricles are beating faster than 40 beats a minute. Okay. You can have rapid heart rhythms, usually a rate of 150 to 200 beats per minute. Electrical activity starts in the ventricle instead of the atrium. This rhythm usually does not allow adequate time between beats for the left ventricle to fill with blood. Then you go into VFib. So VFib is just like the difference between AFib and VFib is just what part of the heart is fibrillating. So fibrillation is just a quivering. It's not actually squeezing and contracting, it is quivering. So AFib is when the atria is quivering. VFib is when the ventricle is quivering. Okay. So you have disorganized, ineffective quivering of the ventricles caused by unorganized electrical activity. What happens when it starts to quiver and it's not contracting? So you've got the blood sitting in this ventricle that you need the ventricle to contract to push that blood out. If it's quivering and shaking, it's not pumping that blood out effectively. Does that make sense?
Yeah.
Okay. Defibrillate is shocking the heart with a specialized electrical current to stop all electrical activity in an attempt to restore a normal rhythmic beat. All right. So defibrillation, we're talking about the fibrillation of the ventricle. It's quivering, so it's not contracting and it's not pushing the blood out. We're defibrillating. So we're going to send an electric current into the heart to stop that quivering. And we're essentially putting them into a systole. It's not that you're shocking the heart into a rhythm that works. You're shocking the heart to make it stop. So when we shock the heart, it puts it into a systole, so it's not working, in the hopes that the heart resets itself and will start beating from that SA node again. A systole, do what?
That's my mind.
Yeah, like a lot of people, if you haven't studied any part of cardiology, you think that you're watching TV shows and you see them shock, clear, and then all of a sudden the heart beats back. They're not shocking them into another rhythm. You're shocking them to stop the heart because the heart has its own conduction system. Its automaticity. It controls itself. So the purpose of it is to stop it. If we can stop it, then the electrical currents are still going. Maybe it'll reset itself. It's like rebooting your computer, or restarting your phone.
That's why we can't shock someone out of a systole.
No. We shock in pulseless VTAC and we shock VFib. That's why when you put them on the AED, it'll say no shock advised or shock advised. You can only defibrillate. You can only shock certain rhythms. We're attempting to defibrillate it. We're attempting to stop this quivering that's going on in the ventricles in an attempt to reset it. So that's why, and you learn in CPR, if it says shock advised and you shock the patient, you immediately start CPR again. You don't check for a pulse. You shock and then start CPR, and then you check after 2 minutes of CPR. It's because the shock is intended to stop the heart. Well, if you stop the heart, you need to do compressions because that heart's not beating.
Yeah.
And hopefully during that 2 minutes of CPR, the heart will restart from the SA node and reset itself. Again, do what?
I said, would you look at that?
Yes. So again, asystole is the absence of all cardiac, electrical, and mechanical activity. All right. These are common cardiac dysrhythmias. The top one is sinus tachycardia. The second one is sinus bradycardia. The one in the middle is ventricular tachycardia. That next one is ventricular fibrillation, or VFib is what we call it. And then the last one is asystole. So the first part of the name of the rhythm, where we said that the top two are sinus tach, sinus brady, and then you have VTach and VFib, that lets you know where the rhythm is generating from. Okay, so those top two that are sinus, that lets you know that those are coming from the sinus, the sinoatrial node. That's coming from the top of the heart, the natural pacemaker. The VTach and VFib are coming from the ventricular nodes at the bottom of the heart. And then asystole is no activity. Asystole may not always be a perfect flat line. You're going to have some waves there. We actually were calling death in the field on a patient one night, and the fire department asked us. They knew the patient was obviously dead, but they wanted a strip printed for the coroner. So we went and put them on the monitor, and like this patient was dead. We knew they were dead. And so we had to put them on the monitor, and then I go to print a strip out. Well, then you start seeing some spikes on the monitor. And one of the guys started freaking out. He's like, he's got a heartbeat. No, that guy that was freaking out was shaking like a leaf and had his foot under my leads, so it was moving those leads and picking up his movement and shining it on the monitor.
Oh my God, I would have died.
Yeah. He almost did. He almost did. It was pretty funny.
I would have just crawled in the nearest ditch and just leave me there.
Good times.
That's something that I would have done.
Right? You would. You will one day. You'll come back and tell us. You'll be like, y'all, guess what I did? All right.
No, I ain't gonna tell nobody that I did.
Yeah. Everybody on scene will tell it.
I try to stay quiet so that people don't think whatever I get up in my hands, so when I mess up, they ain't gotta make me cook with it.
They'll describe you.
The girls that y'all work with that have the shaved head, and I'm gonna be like, oh, thank you.
Yeah, they will. They'll describe you. All right, cardiogenic shock. This is often caused by myocardial infarction. The heart lacks enough power to force the proper volume of blood through the circulatory system. It may be differentiated from hypovolemic shock by the chief complaint, which could be chest pain, dyspnea, tachycardia. The heart rate, it could be bradycardia or excessive tachycardia. Peripheral edema, dysrhythmias, jugular vein distension, or crackles or rails on auscultation of breath sounds. What is peripheral edema?
Swelling in the feet.
Swelling in the feet, the hands, the arms, the legs. So your peripheral, that's your extremities. Any swelling in those, that's peripheral edema. And the same initial evaluation and treatment as the patient reporting chest pain occurs here. You're going to have signs and symptoms of anxiety or restlessness, air hunger. They're gasping for breath. They can't get enough air. Pulse rate will be higher than normal. It can also be characterized by rapid and shallow breathing, nausea and vomiting, and a decrease in body temperature. And the blood pressure will fall below the normal level. Your treatment: position the patient comfortably. Administer oxygen as needed to maintain a SpO2 greater than 94%. Assist ventilation as necessary. Preserve body heat. Gain IV access. Provide prompt transport to the closest, most appropriate emergency department, and call paramedic for backup if available. Heart failure. This occurs when the ventricular myocardium can no longer keep up with the return flow of blood from the atria. It can occur anytime after a myocardial infarction, heart valve damage, or long-standing high blood pressure. It usually happens between the first few hours and the first few days after an MI. There's a difference, okay? Heart failure is like an umbrella statement. You have left-sided heart failure, you can have right-sided heart failure, you can have one without the other, and then you can have both. So left-side heart failure is a pumping function of the left ventricle, can be damaged by coronary artery disease. It can also be damaged by diseased heart valves or chronic hypertension. Why does it keep saying this about chronic hypertension? If you have long-term high blood pressure or uncontrolled high blood pressure, whether your medicine's not working or you're not taking your medicine properly, what effect does that have on the heart?
It damages the vessels because of all the pressure.
What else does it do? So it goes into this in this next statement. Your heart rate increases and left ventricle enlarges to increase the amount of blood pumped each minute. So your heart's a muscle. If it is high, if your blood pressure is high and it's having to pump against this force, it's meeting resistance, so it's having to pump harder. What happens when you go to the gym and you're working out your muscles? What happens to them?
They grow.
They grow, they get bigger. Your heart's a muscle. So the more it's having to work to fight against this increased pressure, the larger it gets. Does that make sense?
It does.
Okay. So untreated or chronic hypertension causes an enlarged heart. This is called congestive heart failure because the lungs become congested with fluid when the heart fails to pump the blood effectively. All right, does that make sense?
Mm-hmm.
Right-sided heart failure. If the right side of the heart is damaged, fluid collects in the body, often showing up as swelling in the feet and legs. Dependent edema is collection of fluid in the part of the body closest to the ground. Pedal edema is swelling specifically in the feet and lower legs. Okay, so let's think about this. Left-sided heart failure, you're going to have enlarging of the heart. Right-sided heart failure, you're going to have peripheral edema. Why is that?
Because when the left-sided heart failure, it can't pump out of the lungs, so all that fluid just kind of sits there. But with right-sided heart failure, it can't pump into the lungs to get rid of all the waste products.
Yeah. So if you think about the mechanics of the heart and how the heart functions, each side of the heart works as a separate pump. Okay, so you have the left side of the heart is pumping out to the body. The right side of the heart is receiving the fluid back from the body. Okay, if the pump doesn't work, things start backing up. So where I'm going with this? So if the left side pump is not working, it starts backing up. So we can't pump out to the body. We're backing up into the heart and the lungs. Okay? The right side pump quits working, so we're not able to pump out the blood that we're receiving from the body. So things start backing up into the body. Does that make sense?
Yes.
Thank you. Okay. Heart failure signs and symptoms. You have orthopnea, Patient is mildly or severely agitated. Chest pain may or may not be present. Distended neck veins. Swollen ankles from pedal edema. Use of accessory breathing muscles. Fluid surrounding small airways that may produce crackles. Productive cough. And delayed capillary refill time. Your treatment is to obtain vital signs, monitor heart rhythm, and administer oxygen as needed. Allow the patient to remain sitting in an upright position with the legs down. Gain IV access. Be reassuring. Gather specific medication taken by the patients and take them along with the patient to the hospital. Administer nitroglycerin if the patient's systolic blood pressure is above 100. What's the purpose of that?
To dilate everything.
Yes. And so you're lowering the blood pressure and you're decreasing the workload on the heart. Pulmonary edema. When pressure in the capillaries exceeds a certain level, fluid passes through the walls of the capillary vessels and into the alveoli. This may occur suddenly with an MI or slowly over months due to chronic heart failure. A common complication of cardiac ischemia. Without treatment, it can result in acute respiratory failure and death. Precipitating causes include heart failure, myocardial infarction, pulmonary embolism, hypertension, and cardiomegaly. Preload and afterload can greatly influence the buildup of pulmonary edema. Treatment is focused on maintaining the airway, breathing, and circulation and transporting the patient for definitive care. So, this is what we were talking about again about the heart not pumping properly and everything backing up. So the pulmonary edema is when that fluid starts collecting in the lungs. Hypertensive emergencies. Hypertension is any systolic blood pressure greater than 140 or a diastolic blood pressure greater than 90. It occurs only with a systolic pressure of greater than 180, a rapid increase in the systolic pressure, or a diastolic pressure of 120. So anything above 140/90 is considered hypertension, but it's not an hypertensive emergency unless one of the numbers is greater than 180/120. All right. Symptoms of a hypertensive emergency are related to the effects of the hypertension. Sudden severe headache is common. Position the patient with the head elevated, transport rapidly to the emergency department, and establish IV access. Monitor blood pressure regularly. Aortic or dissecting aneurysm. An aortic aneurysm is a weakness in the wall of the aorta. Dissecting aneurysm occurs when the inner layers of the aorta become separated, allowing blood to flow between the layers. Uncontrolled hypertension is the primary cause of dissecting aortic aneurysms. Signs and symptoms include very sudden chest pain located in the anterior part of the chest or in the back between the shoulder blades. The pain of a dissecting aortic aneurysm usually comes on full force from 1 minute to the next. Table 18.1 compares acute myocardial infarction and dissecting thoracic aortic aneurysms. These happen very fast. Your patient may be having some pain or some chest pain or some pain between the shoulders, and they're like, gosh, that hurts. And then within a minute, they're pale, they're pouring sweat, they're so diaphoretic, and they're screaming in pain. And it feels like a lot of times they will use the exact words. They feel like it's being torn. Like I feel like I'm being torn apart or somebody's tearing me in half or being ripped. It is a very sudden, very serious pain. Patient assessment: perform a thorough assessment no matter what the patient says. It is imperative that you recognize a sense of urgency for reperfusion when the patient receives no relief with medications. Throughout the call, provide emotional support for the patient and an explanation for the family. In your scene size up, always ensure the scene is safe for you, your partner, your patient, and bystanders. Look for and address any hazards and assess the scene for the potential of violence. Identify the nature of illness and remember not to become fixated on a specific condition. A lot of these conditions are going to come in multiples, even if it's primarily a chest pain. You may have nausea and vomiting. You may have abdominal pain, back pain, neck, jaw, arm, shoulders, shortness of breath. So a lot of times in these medical complaints, you're going to have more than just one complaint. Your primary survey: form a general impression of the patient's condition to recognize and address life threats. Decreased level of consciousness may be an indication of decreased perfusion to the brain. Perform a rapid full body scan of the patient. An AED should be applied as soon as it is available if the patient is pulseless, not breathing, which is apneic, and unresponsive. Quickly assess for any major bleeding that needs to be controlled or any substantial edema in dependent areas. Determine the rate, quality, and degree of distress of respirations. With cardiac patients, breath sounds may be affected by the presence of fluid buildup. Auscultate for crackles or congestion that indicates pulmonary edema. If available, consider the use of CPAP when needed. What does CPAP do for that?
It pushes everything back down.
It pushes the fluid out of the lungs. After assessing the airway and breathing, assess the patient's circulation. Determine the rate, rhythm, and quality of the patient's pulse. Assess the patient's skin condition, color, moisture, and temperature, as well as capillary refill time and skin turgor. We remember what turgor is? The tinting of the skin when you pinch it to see if they're dehydrated, if it absorbs the fluid and pulls back down, or if it stays tinted up. That's the turgor. And you describe it as good turgor or poor turgor. Make a transport decision based on whether you were able to stabilize life threats during the primary survey. History taking. Determine and investigate chief complaint and history of the present illness. Not all patients experiencing an acute MI have the same signs and symptoms. A chief complaint of chest pain or discomfort, shortness of breath, or dizziness should be taken seriously. Answer questions in a professional manner and provide emotional support. Determine whether the patient is experiencing chest pain or discomfort and whether there are any other signs and symptoms. Determine whether the patient is having respiratory difficulty. Ask about other signs and symptoms that are commonly found, such as nausea and vomiting, fatigue, headache, and palpitations. What are palpitations?
Where you can feel your heartbeat.
You feel it. They may say, I feel like my heart's racing, or my heart's running away, or my chest is pounding. Those are palpitations. Obtain the sample history. Ask about medication allergies. And Table 18.2 in your book lists the OPQRST questions. Ask the following questions specific to a cardiovascular emergency. Have you ever had a heart attack? Have you been told that you have heart problems? Do you have diabetes? Have you had any problems with your blood sugar? Have you ever had kidney disease? Do you have any risk factors for coronary artery disease, such as smoking, high blood pressure, or high stress lifestyle? If you work in EMS, you have a high stress lifestyle. Secondary assessment. Evaluate the patient's circulation by assessing pulses at various locations. Assess the skin color, temperature, and condition. In addition to the cardiovascular system, examine respiratory system for signs of inadequate ventilation. Auscultate breath sounds for depth, quality, and any adventitious sounds. And remember, adventitious is anything that's not a normal breath sound. Reassess the level of consciousness. Measure and record the patient's vital signs, including the pulse, respirations, and blood pressure. If you suspect stroke or an aortic aneurysm, obtain a blood pressure reading in both arms and compare the measurements. Repeatedly obtain the vital signs at appropriate intervals. So why would you obtain blood pressure readings in both of the arms and compare them? Why would you expect the blood pressure to be different in different arms? Somebody was listening to talk. Who was that?
Sorry, Rocky decided he wanted to yell at our neighbors.
Oh,
Because you check them in both arms because there should be a significant difference because of the blood flow.
because of that, because of the blockage.
Yeah.
Absolutely. So that is a very good indicator that you do have an aneurysm present, is that the blood pressure is different on the opposite side of the body. Does that make sense? Yes. Okay. Reassessment. Repeat the primary survey to check whether the patient's condition has improved or is deteriorating. If cardiac arrest occurs, you must be ready to begin automated defibrillation or chest compressions immediately. Provide prompt transport to the closest appropriate facility. Treatments such as clot-busting medications or angioplasty should be started as soon as possible after the onset of the attack. A report to the hospital by radio or cellular telephone while en route should be given. Document your assessment of the patient's response to the intervention, and the time of each intervention must also be recorded. Emergency medical care for chest pain or discomfort. Treatment of the patient begins with proper positioning. Patients who do not tolerate being positioned supine should be allowed to sit up. Provide oxygen as needed and maintain SpO2 at 94% or higher. A patient who is unresponsive or in obvious respiratory distress may need assistance with breathing. Use a BVM or a positive pressure ventilation device. Gain IV access as long as it doesn't cause a delay in transport. Depending on local protocol, prepare to administer aspirin and assist with prescribed nitroglycerin. And if you don't know, a shorthand or abbreviation form for nitroglycerin is capital letters NTG. This relieves pain of angina by increasing the size of the vessels to increase oxygenation to the hypoxic tissue. It relaxes the muscles of blood vessel walls, dilates coronary arteries, increases blood flow and the supply of oxygen to the heart muscle, and decreases the workload of the heart. It also dilates blood vessels in other parts of the body. It can sometimes cause low blood pressure and or a severe headache. Other side effects include changes in the physician's pulse rate, including tachycardia or bradycardia. Administering nitroglycerin. Check the condition of the medication and its expiration date. Wear gloves when handling nitroglycerin. Obtain permission from medical control to administer prescribed nitroglycerin. Follow local protocols for administration of additional dosages of nitroglycerin, and your skill drill 18.1 lists the steps to administer the nitroglycerin. Heart surgeries and cardiac assistive devices. Hundreds of thousands of open heart procedures have been performed to bypass damaged segments of coronary arteries in the heart. Coronary artery bypass graft. You'll hear those called CABG. If anybody ever tells you I've had a CABG, that's what that is. It's a CABG, coronary artery bypass graft. It's a blood vessel from the chest or leg. It's sewn directly from the aorta to a coronary artery beyond the point of the obstruction. Patients who have undergone a bypass graft will have a long surgical scar on their chest from the procedure. That's called a zipper. The percutaneous transluminal coronary angioplasty aims to dilate the coronary artery. Chest pain in a patient who has undergone any of these procedures should be treated the same as chest pain in patients who have not undergone any heart surgery. If the patient ever tells you that they've had a bypass, ask them how many. That's just like a collective term for that procedure. They may have just had one artery bypassed, and they may have had, 5 or 6. So always ask them how many bypasses they've had done. Pacemakers. They are inserted when the electrical conduction system of the heart is so damaged it cannot function properly. Deliver an electrical impulse through wires that are in direct contact with the myocardium. If a pacemaker does not function properly, the patient may experience syncope, dizziness, or weakness. A patient with a malfunctioning pacemaker should be promptly transported to the emergency department. An automatic implantable cardiac defibrillator. These are called AICDs. Patients who survive cardiac arrest due to ventricular fibrillation have a small automatic implantable cardiac defibrillator implanted. It is attached directly to the heart. The patient should be treated like all other myocardial infarction patients. Treatment should include performing CPR, beginning with compressions, and using an AED if the patient goes into cardiac arrest. External defibrillator vest. This is a vest with built-in monitoring electrodes and defibrillation pads. The monitor provides alerts and voice prompts when it recognizes a dangerous rhythm and before a shock is delivered. If the patient is in cardiac arrest, the vest should remain in place while CPR is being performed unless it interferes with compressions. To remove the battery from the monitor and then remove the vest. Any patient who is wearing a device that has already delivered a shock should be transported to the hospital for further evaluation. A left ventricular assist device, or an LVAD, is used to enhance the pumping of the left ventricle in patients with severe heart failure. There are several types of LVADs. The most common ones have an internal pump unit and external battery pack. If you are unsure of what to do when the LVAD malfunctions, contact medical control for assistance. Transport all LVAD supplies and battery packs to the hospital with the patient. These patients are going to have, it tells you that the actual pump is inside and it has an external battery pack. So those wires that come out to the battery pack, they have to come out through the body. So you will see those wires come out from the abdomen. And be very careful when you expose your patient, especially if it's a cardiac arrest and you're cutting clothes off. Be very careful. Don't be easy. Do not kill any. Be careful not to cut those cords. All right, cardiac arrest is complete cessation of functional cardiac activity, either electrical, mechanical, or both. It is indicated in the field by the absence of a carotid pulse, and it may be the result of trauma or numerous medical conditions. Automated external defibrillation. Portable automated defibrillator can automatically administer an electrical shock to the heart when needed. All models of AED machines require a certain degree of operation interaction, beginning with applying the pads and turning the machine on. Many AEDs use a computer voice synthesizer to advise the operator what steps to take on the basis of the AED's analysis. Fully automated AEDs deliver the shock automatically. There are few fully automated AEDs left. AEDs also come equipped to give a monophasic shock or a biphasic shock. Monophasic sends the energy in one direction from negative to positive. Biphasic sends the energy in two directions. AED advantages. The machine is fast and delivers electrical shock for the patient in ventricular fibrillation or pulseless VTAC. It can be delivered within 1 minute of your arrival at the patient's side. They are easy to operate. Paramedics do not have to be on the scene to provide this critical intervention, and a shock can be given through remote adhesive defibrillation pads. Rationale for early defibrillation. There are 5 links in the chain of survival: recognition of early warning signs and immediate activation of EMS, immediate CPR with emphasis on high-quality chest compressions, rapid defibrillation, basic and advanced EMS care, and ALS and post-arrest care. If any one of the links in the chain is absent or delayed, the patient's chances for survival diminish. Rapid defibrillation is the greatest determinant for survival. Defibrillation works best within 2 minutes of the onset of cardiac arrest. Integrating the automated external defibrillator and CPR. Know how to work the AED into the CPR sequence. Do not touch the patient while the AED is analyzing the heart rhythm and delivering shocks. Stop CPR and let the AED do its job. Automated external defibrillator maintenance. Become familiar with the maintenance procedures required for the AED. Read the operator's manual. An error is usually because of failure to charge or maintain the AED, failure to use the AED correctly, application of an AED to a patient who has a pulse. If the AED fails while you are caring for a patient, report the problem to the manufacturer and the U.S. Food and Drug Administration. Medical direction. The medical director of your service should help to teach you how to use the AED. In most states, AED training in an advanced EMT course is not permitted without approval by state laws, rules, and local medical direction authority. There should be a review of each incident in which the AED is used. Emergency medical care for cardiac arrest. You have CPR. It increases the patient's chance of survival. Push hard and fast and ensure the chest completely recools between each compression. Do not interrupt compressions unless absolutely necessary. Preparation for defibrillation. An AED should be the first equipment you get from the ambulance for an unresponsive patient with CPR in progress. Remote defibrillation using pads allows you to distance yourself safely from the patient. Do not defibrillate a patient who is in pooled water. You can defibrillate a wet patient, but first wipe the water from the patient's chest. Why are we so adamant on not using this near water?
Because electricity flows through water.
Absolutely. Carefully remove any nitroglycerin or other medication patch from the patient's chest and wipe the area with dry gauze before defibrillation to prevent ignition of the patch. Do not set your patient on fire. Yes. Shave a hairy patient's chest before pad placement to increase conductivity. Indications for not initiating resuscitative techniques include rigor mortis, dependent lividity, and decapitation. What's dependent lividity? So just like we talked about dependent edema, so dependent is the part that's closest to the floor. That's the part that you're laying on or is hanging, and fluids are going to drain to that area. So the dependent lividity is when the blood pools.
Is
So
that line of demarcation that's all in there?
yeah, you're going to see everything sagging and drooping to that area. If the patient is sitting up when the cardiac arrest occurs, and nobody, say it's hours before you find them, the legs and the feet will be purple because the blood has pooled there. Patients that are bedbound, if you roll them over, if they're pale, I mean, they're pale as a sheet, and you roll them over, and you see just the pools of blood that has gathered at their back. Do y'all know what I'm talking about when I say that?
Yes.
Okay, that is dependent lividity. All right, performing defibrillation. Prepare with standard precautions en route to the scene. On arrival, make sure that the scene is safe. Immediately after each defibrillation, resume high quality CPR with compressions first. Skill Drill 18-2 lists the steps for AED use. If the AED advises no shock and the patient has a pulse, check the patient's breathing. Ensure that proper airway techniques are used at all times. Gain IV access and initiate fluid therapy based on patient status. Patient care after automated external defibrillator shocks. Follow your local protocols. Patients who are successfully defibrillated by an AED will develop a normal heart rhythm. Patients who do not regain a pulse on the scene of the cardiac arrest usually do not survive. Further steps depend on your EMS system's protocols. If paramedics are responding to the scene, the best option usually is to stay where you are and continue the sequence of shocks and CPR. If you transport a patient while performing CPR, you need a plan for treating the patient in the ambulance. This figure shows the AED algorithm. Make sure that you go over and note that. Cardiac arrest during transport. If you are traveling to the hospital with an unresponsive patient, check the pulse at least every 30 seconds. If a pulse is not present, stop the vehicle. If the AED is not immediately ready, perform CPR until it is available. Analyze the rhythm. Deliver one shock if indicated and immediately resume CPR. Continue resuscitation according to your local protocol. If you are en route with an alert adult patient who is having chest pain and becomes unresponsive, check for a pulse. Stop the vehicle if no pulse is present. If the AED is not immediately ready, perform CPR until it is ready. Analyze the rhythm, deliver one shock if indicated, and immediately begin CPR. Begin compressions and continue resuscitation according to your local protocol, including transporting the patient. Management of return of spontaneous circulation, also known as ROSC. Return of spontaneous circulation is the restoration of a pulse after cardiac arrest. Monitor for spontaneous respirations. Provide oxygen via a BVM at 10 to 12 breaths a minute to maintain the EtCO2 between 35 and 45. Maintain an oxygen saturation between 95 and 99%. Assess the blood pressure and determine if the patient can follow voice commands. Transport the patient to the closest appropriate facility depending on local protocol. Cardiac monitoring. Some EMS systems will allow advanced EMTs to place electrodes, attach the leads, and obtain an ECG tracing prior to transport. For an ECG to be reliable and useful, the electrodes must be placed in consistent positions on each patient. your guiding principles. You may occasionally be necessary to shave the body hair from the electrode site. To remove oils and dead tissues from the surface of the skin, rub the electrode site briskly with an alcohol swab before application. Attach the electrodes to the ECG cables before placement. When all electrodes are in place, switch on the monitor and print a sample rhythm strip. If the strip shows any interference or artifacts, verify that the electrodes are firmly applied to the skin and the monitor cable is plugged in correctly. Skill Drill 18.3 shows the steps for performing cardiac monitoring. Alright, so on this image, you have your limb leads. That's the white, the black, the green, and the red. You are going to see those labeled as LA, RA, LL, and RL. That stands for right arm, right leg, left arm, left leg. Okay. So an easy way to remember those that are color coded. Some people will say salt, pepper, ketchup, guacamole. Some people will say clouds over grass, smoke over fire. Do those make sense to you?
I've always learned salt, pepper, ketchup, pickles.
Pickles. Pickles a good one because a lot of people don't like guacamole. But yeah, so those are simple ways to remember those. Now your actual placements for your 12 leads. So those are your V1 through V6. So if you noticed, it's called a 12 lead, but you only have 10 actual leads. Does anybody know the reason for that?
Oh, you've told me this before, and I can't remember.
Yeah. So just like we were talking about monophasic and biphasic when we were talking about the AED, how the monophasic sends energy one direction and biphasic sends it two ways. Two of these leads are actually bipolar leads. So the energy is transmitted two different ways. So on those two leads, they're actually acting as four leads that give you a total of 12 leads. Does that make sense?
Which leads are it? Is it?
Why would you ask me that?
Oh,
Um,
sorry.
I think it is the. No, I'm not even gonna. I'm gonna look it up and tell you because I don't want to tell you wrong and then nobody actually listen when I actually look it up and tell you. So I'll come back to that. So the positioning of the V1 through V6 leads. Um, you're going to position V1 and it's actually going to be, if you see it's counting the ribs 1, 2, 3, and 4, the space under the fourth rib. What's that space called? Your intercostal. Your intercostal. Okay, so in your fourth intercostal space on each side, about 2 inches away from the center of the chest. So it's going to lie on each side, the right and left of the sternum at the fourth intercostal position. And that is typically nipple line area. Okay, so that's your V1 and your V2. You're going to skip to your V4 when you're doing your placement. You're going to place V1, V2. You're going to skip to V4, and that is going to be mid-clavicular right under the breast. Okay? So you go to the mid-clavicle line and come directly under the breast, and that's where you place V4. V3 is going to go at a diagonal angle between V2 and V4. All right? And so then V5 is going to be your anterior axillary. Remember, axillary is under the arm. So the anterior axillary is going to be the imaginary line that would come at the front of the shoulder down the side. Does that make sense? And it's going to come almost in line with V4. All right. And then your V6 is going to be mid-axillary. So you're going to go under the arm about halfway and then come down to about that fifth rib and place that there. Do we have any questions?
Other than my lead question, no.
Other than your lead question, no. All right. Is Mighty still with us? Mighty ran away. Um,
Is it really just the four of us?
I'm sorry.
Is it really just the four of us? Just the four.
Just the four of us, and I'm not quite sure if Mighty's here.
Just the three of us. I'm still here, huh? Oh wait, sorry, you're recording.
I am recording, so everyone heard you say that.
I'm sorry. My God, just I want to get into a ditch for you. That's funny.
That is very
I mean,
funny.
usually I'm singing Hakuna Matata, so.
I mean, yeah. So, okay. So actually, the
Hold on, can I take a guess before you tell me?
I mean, you can try.
I'm gonna go with. Is it V1, V2?
No. Like I was thinking it was the arms. Because that's what I remember being taught is it crosses the chest twice. But actually, and this goes way further into cardiac than you need to know. It's just a fun fact. But actually the arm leads, bilateral arms, and the left leg form a triangle.
Oh wow.
Yes, and it is called the Einthoven triangle, which is not something that you would ever need to know, but just the it's either yeah, kind of like Beethoven, but Einthoven, yeah, it's like Beethoven, but it's Ein, EIN. So it's Einthoven's triangle, where it kind of forms this circular, or not circular, but triangular wave of energy. So that's a fun fact. I did not know that. I was thinking that it was the arm leads, but I did not know that the left leg was involved in that. So I learned something new today too.
Would you look at that?
Right? Fun facts. So that would be a very good like bonus discussion question. Why is it called a 12 lead, but there's only 10 leads? Describe what you know. Describe what you know about this situation. So
I'm gonna put Beethoven, like Beethoven with the I.
yeah, I. So well, that is it for your cardiology section. Does anybody have any questions, concerns, comments? No.
That's pretty good.
All right.